So good evening, everybody, and welcome for all from the EIZOC Secretariat. Today is the first ARC webinar for the EIZOC. Our topic is diabetic macular edema, and we had with us our ARC chairman, Dr. Ching Sui, who has taken all the pains to arrange the program, the webinar, and today's speaker is Dr. Shotten Deka, and we had our moderator, Dr. BNR Subudhi sir, and the panelist, Dr. Ranel. And with this, I hand it over to our President, Pranab Ranjan sir, to continue with the program.
On behalf of EIZOC, I welcome again today's speaker, Dr. Satyen Deka, panelist, Dr. Pooja Sinha, and Dr. Ronel Sayoban, our moderator, Dr. BNR Subudhi, a panel of residents, and the audience. Professor YC Mehti, our chairman ARC, has put in a lot of effort in making this program possible. And we look forward to many such useful activities from ARC Brigade, which will not only benefit the residents, but everyone. The program has been well supported by our secretary, Dr. Swaraj Bhattacharya, Chairman Scientific Committee, Dr. Sabyasachi Patnaik, and all the executive members. Let us move forward with today's discussion on diabetic macular edema by Dr. Satyen Deka. So over to you, Dr. Swaraj.
Yeah, may I now request our ARC chairman, Dr. Ching Sui, to continue with the program. Over to ARC chairman, sir.
Very good evening, everyone. Learned senior, respected seniors and my colleagues and my dear residents. Today is the first session of our ARC EIZOC, and we have a very prominent speaker on a very important topic in the form of Dr. Satyen Deka, and we have got Dr. Pooja Sinha and Dr. Ronel Sayoban as the panelists, which will be, this session will be moderated by none other than Dr. BNR Subudhi, Professor. Just brief introduction, he in the EIZOC circle, Professor Subudhi doesn't require much of introduction, but he is the chairman of Ruby Eye Hospital, Berhampur, Orissa. Then his MS ophthalmology from MKCG Medical College, 1984, and then he has been working in that institute from the capacity of a lecturer and retired in 2018 as professor and head of department. He has numerous scientific papers in various national, international journals and presented various papers on the national and international conferences. He has been twice a member of the managing committee of the All India Institute, All India Ophthalmological Society. I hand over the proceedings, the moderation to Professor and BNR Subudhi, please, sir.
Subudhi sir, please unmute yourself.
We can't hear you, sir.
So please unmute yourself.
Subudhi, sir.
Okay, I'm sorry. Right. Okay. Am I audible now?
Yes. Yes, sir.
Okay. So thank you, Dr. Chingsui, by asking me to moderate this today's session, the first session ARC EIZOC program. Really, I'm really honored to introduce our speaker of this evening, Dr. Satyen Deka, my friend, my younger brother, you can say. He's a senior consultant in charge of retina service at ASG Eye Hospital, Guwahati, India, since February 2017. He's a renowned eye surgeon of the Northeast. Not only is very famous in Eastern Zone, also very famous in all over the country. And he has given a lot of experience of giving quality eye care to thousands of patients for more than 2 decades. As a national account retina surgeon, Dr. Deka is a pioneer in sutureless retina surgery in ROP screening and treatment in Northeast India. performed thousands of complex vitreoretinal surgeries and having a huge experience of modern phacoemia cataract surgery too. He's got a lot of interest in ocular oncology, uvea, and neuropophthalmology too, and also involved in a number of ophthalmic research and training faculty for more than 20 years. Several publications, articles in various journals, textbooks, etc., including peer-reviewed journals like EIZOC, Retina, and JCRS, conducted several national scientific sessions and delivered a number of guest faculty talks, symposium lectures, and instruction courses in national, journal, and state conferences. More than 200 presentations in different international, national, journal, and state conferences. I have the honor of introducing the speaker to you. Welcome, Dr. Satyen, for the today's program. And we have two panelists today. One is Dr. Pooja Sinha, is very famous again, who is well known in Eastern Zone and also in all over India. She is the head of the Vitreous and Retina Service at ABI Institute, Patna. Did her VR fellowship at Shankar Netra, Chennai fellow at the Stanford Hospital, USA, and Oxford at Hull Infirmity. She is the recipient of Dr. D.K. Bose Gold Medal and IRC Gold Medal. Has delivered extensive lectures in Indian ophthalmoscopy, national and international forums, and delivered orations and talks in numerous conferences. And other panelists today, we have Dr. Ronel. Again, Dr. Ronel is a really wonderful surgeon, and he is a vitreoretinal and cataract surgeon too. He did his medical schooling from Gajaraja Medical College, Gwalior, and completed MS ophthalmology from Assam Medical College, Dibrugarh. He did his general fellowship and vitreoretinal fellowship from the Sri Shankardev Netralaya, Guwahati, and joined as vitreoretinal consultant in the year 2009. He has done more than 10,000 vitreoretinal related surgery till now. His field of interest is in macular hole surgery, diabetic TRD related surgery, ocular trauma management, and retinopathy prematurity. He has worked as a senior consultant in Sri Shankardev Netralaya, Guwahati for 12 years, and after that he started his own hospital. I think he is the chairman and managing director of Eastern Eye Foundation Research Center, Impal. And visiting senior consultant in vitreoretinal department, the Eye Care Center, Guwahati, and Site Plus, the Eye Care Center, Jorat. He's got a lot of publications to his credit. And so these few words, I introduced both the panelists to the session today. Now it's over to, of course, today's postgraduate students being Dr. Saloni Goel from Agartala, Dr. Irak Devnath, Agartala from AGMC Agartala, Dr. Gullin Kaur from Susudai Hospital, Calcutta, Dr. Bibhudat Pradhan, and Dr. Tenjin Jansen from RIMS Impal. So these are the postgraduate students or residents. They will be interacting with the speakers and panelists with us today. So with this, I thank you once again, giving an opportunity to moderate the present speaker today. And now it is over to the speaker to start his lecture. So over to Dr. Satyen.
Yeah, thank you, sir. So I will share my presentation here. Is it visible now?
Yes,
Yes, sir, it's visible, but it's not full screen.
Okay, full screen. Slideshow. One second. What happening? I think 1 second. Let me start again. Share screen. Full screen now?
Yeah.
Yes. Yes. It is full screen now.
Okay. So this evening we are going to discuss something on diabetic macular edema management. And I believe diabetic macular edema is one of the most commonly discussed posterior segment problem in this present day-to-day practice. And lots of investigation, lots of treatment strategy, lots of money has been put for the management of diabetic macular edema, and we'll go step by step what is happening in this particular diabetic macular edema management, and how we are just going step by step from the very beginning till what is happening at this present. So all of you must be knowing that the magnitude of the problem is so serious. If you see the data, the global prevalence of diabetes in the working age is 10.5. That means 536 million. 536 million people in 2021 data, and it is expected to be 783 by next another 20 years. So it gives a concern that so many diabetic people globally, and diabetic retinopathy is one of the major complication of diabetes, which lead to visual problem, which leads to visual loss. And if you just know that diabetic macular edema that we are going to discuss today is the commonest cause of visual loss in diabetic retinopathy. Now, as there are some postgraduate students, interns are there, and we have our senior colleague also. So many things we are learning in the field of diabetic macular edema in the etiopathogenesis. Now, the things are changing with time. Then lots of new machinery has come, lot of new investigative approaches come, and now we are shifting our thought process from point A to point B to point C. That means once we thought that some herbs will act, then laser, then other treatment. So there are different aspects of the treatment and different aspects of the etiopathogenesis. Now, all of you know it is a common known thing that major risk factor for diabetic macular edema is the persistent hyperglycemia and the duration of diabetes. So duration and the hyperglycemia, these two are the major risk factors. And there are other risk factors associated with diabetic macular edema: hypertension, anemia, dyslipidemia, nephropathy, smoking during pregnancy, cardiovascular disease, and of late nowadays, we also know that sleep apnea itself can raise the diabetic macular edema cases. So this is something new that we have seen. Apart from the previous list, some new things are coming to the list of risk factors. Now, let us go to the real anatomy. I know this, all these students, we have all these junior colleagues, that there are 10 layers of retina, and if you see the macular tree, you just see the macular here. I am just trying to show you how the concept of diabetic macular edema pathogenesis is changing with time. See, this is the retinal anatomy now with this upgraded machines in OCT. We can see all the layers of retina in a cross-sectional view, and even we can see up to the choroid also. Here, if you can see these different layers properly delimited, you can see properly different layers: nerve fiber, ganglion, inner plexus. These were some time back, it was theory only. During our earlier days, only we did laser treatment for diabetic retina macular edema. We never knew that something so gross, something beyond our thought can happen. And if you just see this, there are 10 layers of retina. And let me show you a little bit more expanded. Even you can see the persistent posterior cortical layers, internal limiting membrane, retinal nerve fiber layer, inner plexus, outer plexus, inner nuclear outer. All these, why I'm showing you, their definite pathology is related to all these structures of retina. And you know the retina is a very vital structure. The center of retina is involved because of these factors. And now how macular edema develops, how macular edema creates problem in the vision. See, this central part, just the 6 millimeter zone of the posterior pole, the macula, is necessary for our central vision, our day-to-day activity. And you see that diabetic macular edema is more common in type 2 diabetes, and this is one of the leading cause. There are some new concepts are coming. You must be knowing that retinal neovascular unit. I think to some people this appears to be new, but this is the concept is not new. I'm just sharing this. The new retinal neovascular unit concept is giving us more in-depth knowledge how diabetic macular edema develop. The neurovascular unit of macula, it comprises of neural cells, glial cells, and the vascular cells. And the interaction of glial cell, pericyte, and neuron promote formation and maintenance of the blood-retinal barrier, and which causes flux of fluid and blood-borne metabolites into the neural parenchyma. Now, we are going a little bit deeper into this. Earlier, we just came to know that blood-retinal barrier, outer blood-retinal barrier, and inner blood-retinal barrier. There is problem in the inner blood-retinal barrier, but beyond that, we didn't know what happened. But now with this new retinal neovascular unit concept, we know there are 3 different plexuses of blood vessel in different layers of the retina and the center. And there is interaction between all these. And the cells in the retinal neovascular unit causes retinal dysfunction. And what happened in diabetic retinopathy? Because of this VEGF and other angioproteins, there is even inflammation, there is problem in this blood retinal barrier, and this whole retinal neurovascular unit is got problem. Little bit more deeper into this subject, let us go. If you just see the nerve fiber layer, one layer of retinal capillaries come there, then outer nuclear layer there, another layer comes, and then outer plexiform layer. The 3 plexus of retinal vasculatures come to this layer. Beyond that, the rest part was taken care of the choroidal vascular and the RP function. So this is an integrated complex, and once we just came to know that only the blood retinal barrier means the loss of pericyte and microaneurysm formation, then leaking of micro. But that is not the only fact. Once these aneurysms form, the pericyte losses, and this pulsing happens, what happens? This complex itself got deranged. First, what happened? It becomes intracellular, then it becomes extracellular. And all these factors, when the retina, the capacity to withstand this extravasation of fluid, till that time, it is okay. Once it goes beyond that, then real trouble starts. So what happened? And all these things happen within this 6 millimeter. You just see there are 9 zones. I'm just showing the central area. Then there are other 8 zones. So this is the area where all these problems starts. And with these new studies that we came to know, several studies has reported that neural abnormality, including neural cell that occur prior to the clinical findings. So the problem starts here. When we clinically see a microaneurysm, clinically see a macular edema, before that the neural abnormality starts. So much of knowledge has come in this diabetic macular edema etiopathogenesis concept. So there are new diagnostic. What are these things? You see that nowadays we speak about the biomarkers, OCT biomarkers of diabetic macular edema. Although the pathogenesis of diabetic macular edema focus mainly on inner blood retinal barrier, nowadays we know that even the choroidal biomarkers are also there. That choroid also has some role in this kind of macular edema. Even OCT angio has shown that all these retinal plexus, layer by layer, it has shown. And so we have a better idea about the anatomy and the pathogenesis of diabetic macular edema. So these 3 biomarkers in the macula, what we see, the central subfield thickness, that is one. cube average thickness, that CAT, and cube volume, that CB. These are the OCT biomarkers. Also, the subfoveal neurosensory detachment is another biomarker where we can see that RPE is also altered. The retinal pigment epithelium has altered functioning because of the hypoxia, and this fluid from subretinal space, it cannot properly drain out, and this causes neurosensory detachment. And what happened in the inner part of the retinal layer, the external limiting membrane get compromised. So once external limiting membrane get compromised and retinal pigment epithelial cells also get compromised, we see this neurosensory detachment in diabetic macular edema. So the basic concept of diabetic macular edema is getting very clear, and this concept are leading us to the newer treatment strategies. Even the intraretinal cyst. What exactly this? If you see the cystic spaces within the macula are the expression of coalescence of extracellular fluid resulting from the malfunctioning of the molar cells. The molar cells get malfunction. It cannot dry out the fluid. And there are different small, large, giant, different types of cystic changes. And large and giant intraretinal cysts affect the outer nuclear layer and damage the ISOS junction. Now again, which causes a irreversible damage. Now, after so many treatments, so many injections, sometimes we see that patient is not getting benefited, vision is not improved. Why? Once the retinal photoreceptor get damaged, it is permanent damage. So if the ISOS junction, that means the retinal outer segment having another two segments, that's inner and outer, that junction, these retinal photoreceptors get damaged, and in these cases there is irreversible visual loss. Even if we with treatment keep the macula dry, vision does not improve. So these are the some things that we have to actually know before going to our treatment. Now this foci, you can see that hyperreflective foci. It can be more than 30 millimeter, it can be less than 30 millimeter. It can involve the inner retina, it can involve the outer retina, and also it can be present in the subretinal space. So have a different pathogenesis. So if it is in the subretinal space, now inflammatory condition is come to the hypothesis. Even the hard exudates in the outer retinal layer, and inner and outer both where we get activated microglial cells. Though hyperreflective foci also some biomarker in diabetic macular edema. Even mixed edema, you can see neurosensory detachment, spongy changes, small cyst, large cyst, a combine of all these things. So this is a different kind of edema where pathogenesis itself involved all these particular zones. And nowadays our new generation, they speak something on drill. What is this drill? Drill is nothing but disorganization of the inner retinal layers. If you just see here, this is the inner retinal layer, this is the outer retinal layer, and in this picture there is resolved macular edema, but vision is maintained. Why? No drill. That drill is not there. Disorganization of the inner retinal layer is not there. But subsequently, if you see this picture, the down picture, if you see there, here what happens, the retinal inner nuclear layer is not properly seen. This is disorganized. So what will happen in these cases, even the macula looks dry, vision will be poor. Okay, so drill has a definite biomarker reasoning for diabetic macular edema management. Even ISOS junction, as I told, it can be a continuous disruption, partial disruption, or it can be completely disrupted. And everything depends on the external limiting membrane, how much it can withstand the pressure, and how much the retinal pigment epithelium is helping. So if ISOS junction is compromised, vision is not going to improve even after good resolution of the macular edema. So this is something in a nutshell about the new concept of this etiopathogenesis in diabetic macular edema. Now coming to the treatment, if we see this can be a pre-laser era, our old generation people will be knowing at that time for diabetic macular edema, there is no proven treatment, and many different modalities of treatment were used with different result, but nothing was very concrete. Then came the laser era. So this is a different play. When 1985, I believe, this ETDRS study has come out, a particular concept of using laser treatment in clinically significant macular edema. So what is clinically significant macular edema? All of you know. So I'll not go into details. I just want to emphasize that from 1985 onward till 2005, 2006, this was the golden era for laser treatment. So only treatment option available was that grid laser or your focal laser to the microenergy and leaking capillaries, and grid laser if there is diffuse edema, and that too only we can see in the clinical picture. FFA has definite role to see whether there is any capillary non-perfusion area, whether the macula is ischemic. If macula is ischemic, the vision is not going to improve. And for the treatment of this diabetic macular edema, we had only the option available at that time was grid laser or the retinal focal laser. But this laser treatment was used to prevent further visual loss. Just listen what I'm telling. This laser treatment were used to prevent further visual loss. It cannot regain back the vision. So this is the situation till this next decade. So 1985, ETDRS study has established, and for next almost 20 years, that was the only treatment option. And some retina surgeons already have stopped doing their treatment at that era. Now the new generation has come, anti-VEGF therapy. Now all the people knows anti-VEGF therapy is the treatment option, first treatment option for diabetic macular edema. This also based on different guidelines. There are 5 major groups which has shown that anti-VEGF treatment works. American guidelines, European guideline, Canadian guideline, ICO, and Asia Pacific. These 5 major groups has established that all of them infer that the mainstay of treatment has shifted from retinal laser to anti-VEGF. See, this is the period after 2005 around. This shifting, this is a paradigm shift from laser to anti-VEGF, and also steroid implant came. All guidelines recommended initial loading dose, and then either you do PRN or do treat and extend, and there are different strategies. So rationale of anti-VEGF, it can be boldly said that there is reversal of visual improvement. Just see, laser treatment, we stop the further decrease of vision, but with anti-VEGF treatment, the vision can be regained back. So that is the advantage, and that is the rationale of using so many anti-VEGF drugs nowadays. There are lots of studies which has established this fact that anti-VEGF and the steroid implant working for diabetic macular edema. So at this moment, we know that ranibizumab, aflibercept, brolucizumab, pegaptenib sodium at one point of time, but not now, and bevacizumab. These are the mainstay of treatment modality. And evidence of DME treatment with anti-VEGF therapy is based on all these phase 2 and phase 3 clinical trials. So there are 3-4 drugs which are being used. And most commonly used is the anti-VEGF Avastin. So Avastin and other medicine, there is a different story why Avastin was not officially suggested for diabetic macular edema treatment, but other medicine, there are different stories. But as of now, whatever the situation, Avastin is the magic drug with high efficacy, insignificant systemic absorption, no experimental toxicity, low cost. This is the only factor which is relatively important for our Indian scenario, and this is why the availability. So Avastin is still one of the major drug of diabetic macular edema treatment as anti-VEGF, apart from all these approved drugs. If you see this bevacizumab treatment has shown improvement, And even in this case, ranibizumab that has also shown improvement in macular edema. Even pegaptanib, sodium also has shown that improvement. And now coming to the dexamethasone implants, that rationale of steroid, how come different hypothesis has come that inflammation plays some role in the development of diabetic macular edema, and there are different studies has established actually that there are inflammatory pathogenesis. So on that basis, this medicine it has come, and it affects the inflammation and VEGF. It stabilizes the junction between endothelial cells and reduces the edema, and it works in both intra and extracellular fluid. This picture shows that down, if you can see this, all this macular edema subsided by using dexamethasone implant. Now, entry of biosimilar. This is something new. What we have seen initially, the first molecule came in this market was Lucentis. So if you are giving Lucentis, that means that is the only treatment. Subsequently, other drugs come. And because of the cost effect, similar medicine was being tried as a biosimilar. And as of now, we know the names of biosimilars are Razumab, Ranizumab, and for aflibercept, Geltrap. So these are the biosimilar that use similar molecule but not the original molecule, and these also work. And different studies has established this can be done. Even these first two drugs are DCC as approved in India. Even for Western countries also there are different biosimilars in different name. Those also being practiced. Now coming to our own guideline. So diabetic macular edema treatment guideline in Indian scenario, this is a combined effort of AIS Diabetic Retinopathy Task Force and our PRSI consensus statement. So these two organizations has worked together to come out with a guideline, and which has recently published in 2021. Before that, in 2015 or 16, there was another guideline there, but this is the recent one. And in these guidelines, two important factors are kept in consideration: the expense and the compliance. See, 1 to 6 injection, then every 1 month follow-up, then if necessary, it may not be very practical for all the patients all the times. So compliance is important, and expense is definitely is everybody knows why it is important in our scenario. So what this two organization has given the guideline, we should have a proper ocular
We can't hear you.
examination. All of you know color fundus, but they also can do this investigation.
We lost his.
Now, coming to the treatment strategy. So if it is non-centered involved diabetic macular edema, then if vision is good, only observe. If vision is not good, suppose vision is less than 6/9, then it can be treated with laser. And clinical signs with poor visual prognosis that already we discussed, that coexist include subfoveal plaque, fibrosis, and macular pigmentation, which should be recorded during our examination. So center not involved, vision good, no treatment, follow-up. If vision is not good, we can do laser. And suppose non-center involved diabetic macular edema after injection of clinically significant center involved edema, then also we can do macular laser if vision is less, and if vision is good, then we can observe. And if the poor prognosis is there, like plaque and ardexorate in the center, we can tell this patient that this is not going to help. And use of lipid layering agent can be done with a physician guideline. So management of center involving macular edema, the treatment naive cases, intravitreal injection, anti-VEGF, first line of treatment, and multiple clinical trials has demonstrated the anti-VEGF therapy is more effective in improving vision in center involving DME than macular laser, and supplement it as first line. So center involving diabetic macular edema, first line of treatment is your anti-VEGF, and you can choose anything out of this: ranibizumab, bevacizumab, aflibercept, and brolucizumab. So dear CRNet protocol, it has given that start with monthly injection, as I told, 4 to 6 months initially. Then vision is improved, you can wait. If vision is worse, again you can go for next dose of injection, and you can extend your follow-up if condition is stable up to 4 months. And there is another alternate regime is treat and extend, wherein the interval between visit is adjusted based on the treatment response. So DRCR net has also tell that anti-VEGF. And when we stop the anti-VEGF therapy, if there is no further improvement and less than 10% decrease in vision, and OCT also shows that then further benefit is not possible, then we can stop. And if it is recurrent DME, again we can restart the anti-VEGF. And if it is non-responder to anti-VEGF, what we'll do? In most common cases, let me tell why it is non-responder, that we do not follow that 4 to 6 first initial injection. It is not practically possible in all cases. Because of that, these are the cases it becomes non-responder. In eyes with persistent DME and visual acuity less than 612, we can think of giving a different anti-VEGF. Suppose ranibizumab is not working, we can shift to aflibercept. We can shift to bevacizumab. If bevacizumab is not working, we can shift to the another one. And this is for under 2 to 3 injection. And suppose after six injection, this is not happening, we can go to the steroid. And steroid has some specific situation. Suppose there is post-vitrectomy cases, and there is hard exudate in fovea, and there are other cases where we cannot give the anti-VEGF because of the some systemic condition. So steroid can be given. And if pseudophakic cases, steroid can be given. So there is a long list. I'll not go into details of this, but everybody knows. And role of vitrectomy, that is very obvious. If there is thought posterior hyaloid or epiretinal membrane, whatever amount of anti-VEGF you give, it will not help. So you need to go surgically. So surgical improvement happens because it releases the hypoxia, and also it releases the traction, and this is a different model. Mechanically, we remove the membrane. Now, some important thing then we usually forget to tell the patient that control of systemic risk factor, that is the most important. Many times these are being overlooked. We just keep on giving injection and we do not know what is the systemic status. So patient systemic status has to be kept stable, and we have to make a networking with our fellow colleague like physician or the nephrologist. So that is most important. And I have a list of 20 different associated findings. Suppose diabetic retinopathy with cataract, what you will do? If it is very early cataract, retinopathy is significant, you treat retinopathy first. One phobia is stable, then you can think of cataract. Suppose very significant cataract, we have to do cataract surgery first. And suppose you can see that cataract is significant, but macular edema is also there, we can combine anti-VEGF as well as cataract surgery. Suppose in glaucomatous eye, what we should do? We should avoid the steroid treatment. We can go ahead with anti-VEGF. Like optic nerve, sometimes what happens, you are giving injection and injection, but you have not realized this patient is having optic atrophy. Just simple color vision test will help you that, okay, this patient is having optic atrophy. So even giving anti-VEGF, so many injections will not help. So there are ample different particular situation where we have to strategically go ahead as per that condition. Suppose patient is having fresh cerebrovascular stroke. So up to 3 months, we should not give anti-VEGF. But if it is more than 3 months, we can start anti-VEGF. And the new entity that has come into this picture is sleep apnea. Many people, even many, these fat people, they will have sleep apnea, and sleep apnea increases diabetic macular edema. So what happens in sleep apnea? You have to do proper sleep analysis. If necessary, they give some assisted option. It helps reduce edema. Hypertension, all of you know that we have to treat hypertension as well as sometimes there is malignant hypertension. The clinical finding will be a little bit different. You will see the disc edema along with. So we have to treat that also. And even a diamine vitrectomized eye. If you sometimes see vitrectomized eye also again develop diabetic macular edema, their steroid is more preferable, but anti-VEGF also works. What we will do in pregnancy? So pregnancy in first trimester we'll try to avoid because this can go to the baby. So we try to avoid all injections at that time. Laser is okay, can be done. Even steroid also okay. So there are almost around 19 to 20 different cases which can be associated with diabetic macular edema. But maybe in the discussion we can discuss some more, because if I go one by one, it will not, time will not permit. So what is new in this anti-VEGF? Faricimab is the Vabysmo 6 milligram per 0.05 ml. This is the new anti-VEGF CAM, which block VEGF as well as angiotensin protein, ANG2. So this is recently launched in India in last our Trivandrum BRSI meeting, and this is already FDA approved. So this is a new phase in the macular edema treatment. So in conclusion, DME is preventable to some extent, and we have to optimize the control of systemic factors, and we have to take a holistic approach where we do a networking with all different doctors responsible for treating the diabetes mellitus. And though anti-VEGF are the first line of management, coexisting ocular disease, as I told you earlier, and associated comorbidities may alter the management strategy. So case to case, we have to judge how we proceed. Thank you very much. So after this, I think we can discuss. Many newcomers are there. Our colleagues are there. So please.
It's a really wonderful discussion. I think you have covered everything from A to Z of diabetic macular edema. So now I invite the panelists to give their comments, and Dr. Satyan's, or if they want to add also anything, Satyan's presentation. So Dr. Pooja, would you like to add something to this presentation?
So I think, as you rightly said, Dr. Satyan has actually covered everything from A to Z. What I would like to emphasize is what he mentioned in one of his slides, that the metabolic control of the patient is also extremely important, because many patients are having kidney dysfunction, or they are very unstable diabetics, hypertensive. So those patients need to be metabolically controlled along with dealing with their diabetic macular edema, especially those with hard exudates in the center of the macula.
Yes, that is.
Dr. Satyan, could you like to stop the sharing our screen?
Okay, stop sharing one second.
Satyan sir, I think you please stop this so that we can see.
The other point I wanted to make was that OCT has really revolutionized the way we treat diabetic macular edema, because now so many biomarkers are there on the OCT which help us understand whether it is more of inflammation or more of VEGF mediated disease. For example, as Dr. Satyan rightly mentioned, if you have hyperreflective dots or you have persistent intraretinal cystic edema, that has to be definitely dealt with the anti-VEGFs, and also they do very well with the anti-inflammatory agents like Ozurdex. So that is the OCT biomarkers have to be definitely considered. Thank you.
Yeah, so right. Yes, OCT biomarkers, they play a major role. Dr. Satyan, would you like to dilate something under these OCT biomarkers? How to, evaluate and how to delineate it for the treatment as well as management?
As I told you, see, the whole concept of the pathogenesis was changed after the new OCTs has come. This OCT are giving a very clear picture of the macula. So now this OCT biomarker, suppose neurosensory detachment, if it is there, then we are sure that there is the RP dysfunction and ELM is already compromised. So neurosensory detachment means these two factors we have to think of. Even if there is, suppose, large cyst and this, suppose the large cyst is there, that means these vital tissues are lost there. So these cases, even with treatment, the visual outcome is not very proper. Like drill, as I told, disorganized this outer retinal layer that we can nicely see in the OCT. At laser era, we never thought about these concepts. So there, if we see that drill is there, then we can counsel the patient that even after all this treatment, visual prognosis is compromised. But suppose neurosensory detachment only, but there is no actual loss of the photoreceptors. With treatment, patient will have a good vision. And as I told, if we follow the protocol, actually 4 to 6 initial injection, then we actually follow the protocol, then the resolution of edema as well as protection of the this photoreceptors as well as the retinal other cells is maintained. So once we start treating a naive patient, we have to discuss in depth with the patient that this is the situation, you need these treatments, and then you follow up. But nowadays, what happens after giving 2 injections, patient will run to a third doctor. He will do window shopping, no? He will go here and he was giving suppose ranibizumab. The third doctor will say, okay, let me start with bevacizumab. The fourth will say that okay, a new drug has come, let us try with that, aflibercept, Eylea. So actually, this causes a khichdi. That means the all these treatment are being it intermingled. So you do not know exactly what is happening. So patient has to be counseled in the very beginning that the treatment is like this. And as I told that there are definite indication for using steroid. We have to tell that. And for anti-VEGF also, it works. We have seen very fantastic results. But this we have to stop. That means one we do a loading dose followed by other treatment. And these OCT biomarkers really help to see whether this is going to improve or not. Suppose IOS-OS junction is disrupted, this patient is not going to be. Even the hard exudates in the center, suppose. So these cases, suppose a proper systemic metabolic control is there and you give steroid, these cases will improve with time. But if the persistent edema is there, the cell will damage, so vision may not be improved. So early treatment, persistent treatment, and your OCT guided, this OCT biomarker guided your approach will help the patient.
Dr. Ronil, would you like to say something about the biomarkers and are they useful for the management of diabetic macular edema? How do they help us?
Yeah, Satyendeka sir already explained all in total. Okay. Anyway, in the OCT eras, we can see OCT biomarkers is very important. And according to the finding of the OCT biomarkers, we can decide whether we have to start with Ozurdex, dexamethasone implant or anti-VEGF. In those patients, in those patients having these hyperreflective dots in the even in the cystic changes inside the cystic changes, we can see some hyperreflective dots. In those cases, I usually start with a dexamethasone implant, and along with this, one of the most important things is the metabolic control also. Metabolic control in terms of lipid profile and all, and in those patients.
Can't hear you, we lost. Yeah.
Yeah.
Yes,
And
yeah.
There is interruption.
Yeah.
Yeah. Okay. Carry on.
Yeah. In those
Dr. Pooja, can you come?
Yeah.
Yes, continue. Dr.
Yes, sir.
Yeah. So something Dr. Deka was mentioning about the drill. So how do you identify this drill and how to manage this? For the DAB treatment.
So as Dr. Deka was mentioning, drill is disorganization of the inner retinal layers. But the good news is that drill is reversible.
Yeah.
So if there is drill and we give anti-VEGF agents, the restoration of the retinal layers is possible if we are aggressive with treatment. So that is one, the happy side to it. Although it is not a very good OCT biomarker to have. And the other thing, many times that we encounter is clumping of hard exudates in the macula. Those are situations which are very tricky. So in my experience, lowering the lipid profile and a good cholesterol control is important. Along with I don't know what Dr. Deka's view is on internal limiting membrane peeling along with vitrectomy. Do you think, Dr. Deka, this helps in clearing of the hard exudates? The ILM peel with vitrectomy and anti-VEGF agents. What is your view, sir?
Even that what my experience and what I have seen, even some senior people also doing vitrectomy cannot improve the vision in this situation. So even ILM peeling, what is the role of ILM? See, ILM it creates a scaffold. Just we remove that scaffold. But these are the situations, these are beyond internal limiting membrane. If you see, this is happening in the inner plexiform layer, in the inner nuclear layer, and it goes beyond that, it will damage the photoreceptor. Our goal is that we should not allow the photoreceptor to get damaged. And sometimes if you see that there are cystic spaces, but if you see the septas, there are some septas, you will be happy that these septas are actually the neural fibers. And in these cases, after treatment, patient vision improved. Though it looks initially very scary that it is not going to improve, but neural tissues are there. It is still viable neural tissue. These cases improve with treatment.
Yes, you have made a very valid point.
I will suggest
because if they are very large,
for vitrectomy. Yeah, but if it is very large, then of course this is not going to help. And my suggestion for vitrectomy and ILM peeling, if you have a taut posterior hyaloid and if it's specific epiretinal membrane, only those cases. Maybe sometime back, it's a quite long time back actually. Before this, at that time where just anti-VEGF came to the market, not very. 2006, we had a retina meeting in Guwahati. Dr. Bill Aylward from Moorfield, he came and he showed some vitrectomy cases where clinically it looks better, but still this hard exudate, it took time to go away. So at that time, he also showed some cases of doing vitrectomy. But when I personally communicated, he told that visual improvement is not very significant even with vitrectomy. So vitrectomy,
I think because of the damage to the photoreceptors.
Right.
So then, yeah. So now we move on to the postgraduate students. Let us ask anything from them. Dr. Gurleen Kaur, are you there? Dr. Tenji, are you there? Dr. Vibhudat?
Yes, sir.
Yeah, come with the video. Come with the video. Do you have any questions to Dr. Satyan?
Yes, sir.
Yeah, please.
Yes, please go ahead.
Please.
If sir, a patient has center involving macular edema with glaucoma, so we are giving anti-VEGF injection. If after giving anti-VEGF injection, the patient's central subfield thickness is decreasing, but IPG increasing very high, then subsequently how will you manage the patient? Will you further go for further anti-VEGF or you do?
If patient is having already established glaucoma,
yes, sir.
So
with
our mainstay of treatment will be only anti-VEGF. So we will go ahead with anti-VEGF only. Now you have to, as I have shown in this 9 zones, no, the only central subfoveal zone thickness we just see it's more than 315. That means we will do treatment. That is not only the biomarker. You have to see all 9 segments. So many times we do mistake. We just see the central thickness. Okay, it is more than 315. Let us go for injection. but we forget to see the other areas. So we have to see the whole map, the whole fovea, because this 6 x 6 millimeter zone, it overall it is necessary for the vision. So what happens? Suppose in cases, as you are telling, if it is established glaucoma, we will avoid this steroid definitely. Anti-VEGF will continue, and we will give the topical medication to treat the glaucoma, whatever is necessary. So we will continue with anti-VEGF.
And sir, I
And
have
of course,
second.
if there is leaking microaneurysm just away from the fovea, suppose there is persistent edema, these cases can be lasered.
And sir, my second question is like for macular edema, we are giving first line treatment anti-VEGF. So to moving on the steroid, how many months we should wait? Is working
6
or not?
injections. 6 injections. At least
Like
6 injections.
Any anti-VEGF injection, then we have to
So
move.
you have to give at least 6 anti-VEGF injections. Still the condition is like that. Then you go for steroid. But as I have given a list of 6 other indications, in these situations, you can start with the treatment of dexamethasone implant itself, not going to the anti-VEGF. Okay.
And so my third question is like in vitrectomy, we can use both corticosteroid and anti-VEGF, but we are preferring corticosteroid. Why we are preferring corticosteroid over anti-VEGF?
This dexamethasone, this is dexamethasone actually. This dexamethasone implant that we use regularly, it is a kind of cylinder. It persists. It gives a long-term release of the drug. And when we do the vitrectomy, this cylinder stays in the somewhere in this anterior part of the this peripheral vitreous cavity. So it gives a persistent release of drug. But otherwise, anti-VEGF, if we give it, it washes away a little bit early. But still, the first anti-VEGF, better than anti-VEGF, we go for steroid in post-vitrectomy cases. But it is not that anti-VEGF will not work. Even if you give anti-VEGF also in these cases, that also work. But this will give a long-lasting effect, 3 months to 4 months.
Thank you.
Thank you.
Dr. Satyan, which anti-VEGF you prefer in your practice?
See, nowadays, first line of always ranibizumab. Now, using ranibizumab, now again, whether biosimilar or a original molecule, that will be depend upon the patient's decision nowadays. And Avastin also we use regularly whenever. After knowing this, we ask the patient to take the decision, because sometimes we get trapped. Suppose if we see a person that we feel that okay, he won't be able to give higher cost medicine, let him give Avastin. We will not suggest other things. Then subsequently, you may be in trouble that this patient actually is a very rich person. Then he may come and say, why you have not given the costly medicine? The people have a feeling, no? If you give a costly medicine, I will get a better improvement.
Yeah.
So let us give all the options in the beginning. These are different options. This is FDA approved and this is off-label drug. Now you can choose. But what we have seen in the different trials like DRCRNet protocol T, I think protocol T, that all these medications works almost similar.
Okay.
So we will ask the patient to decide. And sometimes patient बोलेगा, sir आप ही बोलिए, you are the doctor, आप ही भगवान है, आप बताइए.
You're the best person.
Then I
to
take my
choose.
decision for this particular patient.
Sir, question from here to Sir Deka. What, according to you, do you think personally, is there any difference between the ranibizumab or a biosimilar, practically, in your own opinion?
No, I don't see.
No, if the patient asks you
Biosimilar
to
also
decide
work. Biosimilar
which
also
drug you
work.
decide, sir.
Mhm.
Pardon?
If the patient
not
asks you to decide which drug you decide.
See, for patient, suppose he is having a proper TPA, like insurance policy is there, and the insurance policy also have their own drug that they want to give. Suppose there are some NPanel organizations. If you write ranibizumab, they will come with
Yes.
a biosimilar. So
Right.
now the goal is in their code. So that's why we give all the options. I do not choose actually. I think everybody is having that experience.
Yeah, yeah.
You suggest ranibizumab, they will come with eccentrics. Suppose if you suggest
Yes, yes.
biosimilar, they will come with eccentrics because their organization is giving eccentrics. Suppose in Dubai, they don't allow anything except Lucentis. So it is a area which is not in our domain actually. Only thing is that if one particular drug is not working for subsequent injections, then we can shift to other medicine. Suppose again the duration, suppose. So aflibercept work for a longer duration. So if patient cannot come at 1 month, so patient can take aflibercept. Suppose you want to come after 3 to 4 months, okay, you go for Ozurdex. Now this Vabysmo, faricimab, it works for 4 months. I think they have told. Maybe within next 1 year or 2 year, we'll have another thing. Now it is really a difficult situation for the doctor to decide the anti-VEGF. So you have to be very intelligent way deciding this, because you do not tell that you take this particular medicine. Sometime no company will come, sir, I will give you 5 injection free for 5 injection. It comes, company come like that. Now that benefit to give the patient, sometimes you will get trapped. They will say, okay, this doctor is having something with the company, so I do not believe him. So be neutral at this point. Be neutral. And as the study has properly shown that all these medicines work similar, except this particular situation where we shift. These guidelines very nicely our this BRSI and AOS guideline has given. So we'll be abide by that guideline. Let us be safer in that side. And even
I wanted to make one comment in this.
Yeah.
Yes.
Since diabetic macular edema is a chronic disease, many times the rule of 3 doesn't really count. We tell the patient, because in ARMD we say, okay, 3 injections are required. But in diabetic macular edema, sometimes more injections are required. It could be 6, it could be 8. So let us not give a specific number to the patients. In practical, this is a practical problem we face. So
what actually happened? Yeah, in this particular situation. So what I have seen some experienced senior doctor also speak. They told that they discuss with the patient like this. So if possible, first 3 injection you give. If possible, give first 4 injection. 4 to 6 as per the guideline. But at least minimum 3 injection you try to give. After that, seeing the condition, we decide. So in the first year, maybe 2 to 3 injection or 4 injection. But if you see next 2nd year, 3rd year, so it reduces actually. So those patients which has course more than 5 years, these patients, they need maybe 1 or 2 injection in a year. So we have to give an overall idea that your overall injection requirement would be this, but you need a regular follow-up, at least 3 to 4 months interval.
Dr. Pranabji, what is your opinion? Your practice, how do you manage?
Look, I'm not a retina person, but
it doesn't matter. Nowadays everybody is doing medical retina.
See, now injection, yeah, that is another situation, because so many patients are there. So everybody now are entitled to give anti-VEGF. So this is not only purely you have to be a retina specialist.
Yes.
So everybody, if they know how to give injection, they know a little bit about small courses. People can take 2-3 months courses and have some hands-on idea, because patient number is very high. So we need to utilize everybody for that.
Yeah, absolutely. Because what information I have that in UK, even the nurses are giving intravitreal. They are entitled to give intravitreal injection. So that way, considering the number of people who are diabetic and going to suffer from diabetic retinopathy and macular edema, I think most of the ophthalmologists, they should know the intravitreal aspect of the activity also.
I think any ophthalmologist can inject. There's nothing harm. I think it's a very simple technique, and there are not too many complications in these injections.
Sir, I think it's not the injection itself is okay. I think anybody can do it. Even a resident should be able to do it. But the decision to, how to give, and then how long to give, and what are the things to follow up, I think these are more important things.
So what I suggest, like people who are not exactly in the domain of retina, let us have at least few weeks course with the retina people that you just learn how to give, how to follow up first day, maybe 1 week or later, and you'll be in touch with a person who can handle if something is necessary. So you be connected with a retina person and you do your treatment. I think that will be the best option, and let us have some hands-on at least, because sometimes the cases happens when very novice, no, your fellows giving Ozurdex, they penetrate the lens. So
I've seen one,
at
sir.
least
I've seen a
one thing I feel that
happens.
any surgeon who is doing cataract and glaucoma surgery, I mean intravitreal injection, because the first intravitreal injection I gave was when I was a house surgeon. Long time back, genticin injection that I gave. So anybody can give an intravitreal injection. The major portion, the major difficulty is how to manage it. I mean, management is the most, how to follow it up. That is the most important thing. And if you got a OCT and a retina person just by the side of you, you can definitely go ahead with that. And
Yes,
with what new drug is coming, Faricimab, what you said? I mean,
yeah, that is GME, that is approved in the US FDA approved.
Yeah.
And there's our Trivandrum meeting now in December that we attended.
It is coming in December.
So with the dual action of the anti-inflammatory action also added to it, and the pathogenesis of inflammation which is also linked to diabetic macular edema, that
this
should
is
be the drug of
anti-VEGF,
choice.
and it blocks two molecules actually. It's a anti-VEGF property, also ANG protein, angioprotein. They told that they block these two particular
and secondly, the
molecules.
duration part also, if it is to be taken 3 or 4 months, that also gives a lot of respite to the patient.
Right.
Yeah.
And then duration, how frequently is the injection required, sir?
3 to 4 months, I suppose, no?
And also again that initial loading dose, then the follow-up, that means at least 3 to 4 months. 4 months they told. That in the Trivandrum meeting, the discussion was that
first 3 injections and then 16 weeks.
16
weeks. But the cost is a problem. So the Singapore faculty was discussing the cost. So
anyway, there will be biosimilar again.
But one question, Dr. Satyan. As you said, the effective management of diabetes is also essential for the treatment of diabetic macular edema. So it has been seen that many anti-diabetic drugs, they also induce diabetic macular edema. Do you have any experience on that? Some of the anti-diabetic drugs, they enhance the diabetic macular edema. So you have to consult the diabetologist.
Yeah, actually, what happens whenever patient comes with the list of medicines, actually more than 80% medicine we do not understand what is written there. And actually we do not know what medicine is given, because being ophthalmologists, we are almost out of this field that only insulin we know. But these medicines, if it really having some problem in diabetic macular edema, but if we are giving the treatment for anti-VEGF, whatever treatment, now it will be difficult to judge whether this medicine is creating problem or not. Yes. So maybe we need some more data before giving any comment. I don't have any personal experience to share actually that this particular drug is causing and this treatment I'm giving. I don't have any particular data.
Ronel, do you have an idea?
Do
you have an experience?
One drug is Gilotazone, but exact name of the drug is don't remember. Gilotazone causes diabetic.
Yes. It is some. I think it is got to do with. It has been shown to worsen and progression of macular edema. So I think it's not used nowadays regularly by this thing.
What we have seen best is insulin. If patient can be kept with insulin, it gives the best stabilization. Actually, what the diabetologists they say.
Yeah, so
because they say that insulin has a neuroprotective role also in retina.
I have one question.
What?
Yes, Ronel. Yes.
It's a patient with drill with a vitreomacular adhesion what exactly do you do directly with vitrectomy, or do you give anti-VEGF or some dexamethasone implant followed by vitrectomy or something?
No, in this situation, you have to see what is the vision.
Ah,
We will be guided by the vision, not only the macular edema and the other findings. We will be
vitreous
primarily
macular
guided by the
adhesion
vision.
with yeah.
And suppose there is drill, there is adhesion. So by doing vitrectomy, this is not going to help. Even so, we have to be we have to be very careful that we do not go for a vitrectomy in these cases also. But just looking at that, no, posterior hyaloid is thought. Sometimes we are tempted to go for vitrectomy. But if you know that the retina is not in a very proper healthy status, so only removing the traction may not help. So we have to be choosy at that point. And as Uza has rightly mentioned, in drill also, some cases, even we can see sometimes vision improves. So there are some factors which are still, it is beyond our knowledge. So I think more research will come and we'll be knowing exactly what is this break point. So vitrectomy should be very careful. If you are sure this, after removing this posterior hyaloid, thick posterior hyaloid or distal posterior ileum, the patient will have better vision, then only. Because our clinical experience, what I have seen, sometimes no, it looks very tempting that we remove this epiretinal membrane. And even the ophthalmologists, they send the patient. I have seen in OCT, this is the vitreomacular traction, do the surgery. But I know this patient is having associated RP atrophy. He is not going to improve with this vitrectomy surgery. So in these cases, even they suggest we will not go for surgery. So these cases, individually you have to decide if retinal function is going to improve after vitrectomy, then only we will plan for vitrectomy. Because vitrectomy cause many things. Again, if it is a phakic eye, patient will develop cataract after some time. Then whatever you do now, patient finally see what is the vision and what are treatment is really effective or not overall. We see the traction, patient see the vision. So we have to think in the patient's perspective that this patient, whether vision will be improved with a particular treatment. If it is not going to improve, we have to be careful. That was the term holistic has come.
Good. I think it's a very good discussion we had today. And
just one thing I would like to add, discussing
please.
whether we should go ahead with the anti-VEGF in a glaucoma patient or not. Definitely, we can go ahead with a anti-VEGF in glaucoma patients also. The only thing one should avoid is the prostaglandin analog like latanoprostanol. That should be avoided. Brinzolamide, dorzolamide, letarosudil, these are all drugs which can take the pressure into account.
But what about the Ozurdex? Ozurdex can be given?
Ozurdex can also be given. Yeah, you have to monitor the intraocular pressure. You have to avoid the prostaglandin analogs. Apart from that, Ozurdex can be given.
And actually speaking, that Ozurdex it's a safe drug. So maybe the incidence of glaucoma is not that very high. And whatever it happens, with one or two medication, it can be controlled. In very rare cases, sometimes this is uncontrolled diabetes. Right. So even giving dexamethasone, no. So you should not be very scary. It can be given. Glaucoma incidence is not that significant.
Correct. So now your remarks, Dr. Sabyasachi, your remarks. I think you have to give the concluding remarks.
No, I must congratulate our chairman ARC, Dr. Singh Sui, for this excellent maiden program he put forth today. And thanks to Dr. Satyan, who covered the DME, diabetic macular edema, so nicely, starting from its pathogenesis, then again neurodegenerative changes that occur prior to vasculopathy, and then subsequently the clinical features and management. We had an excellent discussion by our panelists, Dr. Pooja and Dr. Ronel. So this is certainly a very good program for all of us to learn something or other. And this is mostly a program by the EIZOC, for the EIZOC, and also of the EIZOC. We are all, starting from our speaker and panelist, and all of us belong to the EIZOC family. So thank you very much, our chairman, Singh Sri sir, President Pranab sir, and Secretary Surajda, and this today's speaker, Dr. Satyan. for this excellent program.
It's over to Dr. Ching Sui now. Dr. Ching Sui, are you there? Can you listen me? Hello.
Yeah, he's there.
He's there, no doubt, but he's not able to hear us, I believe.
I think he's switched off.
No, he's not switched
Switched
off.
over to his mobile phone, actually. Must have
Yeah.
gone something with the laptop.
The secretary is coming.
Dr. Siraj, now?
Yeah, Century has come.
Ching Sui has come.
Yeah, yes, come.
Microphone.
You are muted. You are muted, Sing Sui sir.
Now you Dr.
Unmute.
Ching Sui, you are muted.
Yeah, I'll just come back. I'm so sorry. My
Over to Dr. Ching Sui, please.
yeah. Thank you so much. My due apologies. Everything went off actually just now. My this thing crashed. So is it for me to give the vote of thanks? Propose. Hello.
Yes,
Yes,
you can.
We can hear you, sir.
I have skipped that. I didn't hear the other part. I'm so sorry, but I want to propose the vote of thanks on behalf of ARC EIZOC. First of all, we would like to thank the speaker, Sir Satyen Deka, for giving a very insightful discourse on this very important topic of diabetic macular edema. It was really, really eye-opening, and then some of the aspects were well highlighted. And even for us seniors, I think it was quite an eye-opener. Also, we would like to thank the moderator, Professor Subudhi sir, for moderating the session so well and incorporating all the discussions for a lively discussion. Also, I'd like to thank our panelists, Dr. Pooja and Dr. Ronel Soibam, for giving valuable inputs and making this discussion really lively. And also our sincere gratitude to our residents who had participated and made this discussion very, very lively. I want to come back again to the president of EIZOC, Sir Pranab Ranjan, for giving it a really hard push so that ARC EIZOC could start its baby step towards a more fruitful existence. The support of our secretary was nonetheless, I think it was there everywhere. He was there every time when you had this thing. Without his support, I think it would have been very, very difficult. And the same goes with our chairman scientific committee, Dr. Sarvesh Satchi. Thank you so much. Again, our sincere gratitude goes to all the members of the ARC EIZOC for making this first inaugural session of ARC EIZOC very, very successful. We hope that this endeavor, with this endeavor, we should be able to go forward and then achieve much more so that the EIZOC states are all benefited. And last but not the least, I would like to thank Anthod Pharma for making the whole exercise feasible and for their financial support. Thank you all, sir.
Thank you.
Thank you.
Thank you. Thank you.
Good night. Good night. Good night.
Thank
Good
you.
night,
Sir.
good night,
Thank you,
Thank you so much.
Thank you, everyone.
Thank you. Sir.
Good night, sir.
Good night.
Good night. Good night.
Thank you,
Thank
Ching Sui.
Good night.
Thank you. Thank you, sir. Thank you.
Thank you.
That was the
It's really,
Thank you.
it's very good.